And the next topic from Professor Martin Weiser from Memorial Sloan Kettering Cancer Center in New York. Professor Weiser, good to see you.
Hi, good.
Hey.
Joe, good to see you as well. I wish we could be there in person.
I'm very sorry because now it's very late night in the New York, right? 10 p.m. or something like that.
Yes, it's very late at night, but it's good to join you, and I'm really happy to be here.
Yeah, sorry. I would like to introduce Professor Weiser. Now he is currently Vice Chair of Education and Faculty Development. And Professor Weiser is one of the leading world experts in colorectal surgery, especially now for the robotic surgery. Professor Weiser served as many faculty members in well-known organizations such as Society of Surgical Oncology, and he published more than 300 international articles with over 21,000 citations and many international book chapters. Today is our great honor to have you here. Professor Weiser will give us a talk about update in colorectal cancer management. Professor Weiser, please.
Well, thank you again. Thank you for the kind invitation. It really is a pleasure to speak with you today. I'm going to spend the next 20 or 30 minutes talking about updates in colorectal cancer treatment. I have no financial relationships that relate to the current talk. So I'm going to talk about, I think, some recent findings and updates that are relevant, and they're outlined here. This includes early onset colorectal cancer, chemotherapy for colon cancer, and I'll talk about the IDEA collaborative as well as the dynamic trial that was just presented at ASCO. And then for rectal cancer, we'll talk about total neoadjuvant therapy, including the RAPIDO and PRODIGE 23 trials. I'll then move on to talk about watch and wait, non-operative management or organ preservation, and I'll talk about the OPRA trial. I'll then talk about the recently presented trial, again at ASCO, on PD-1 blockade for primary MSI rectal cancer, very exciting. And then I'll end with the prospect trial and some thoughts. So the incidence of colorectal cancer has been going down in the past 60 to 80 years for all comers, both for male and female. The incidence and mortality has been going down. However, if you look more carefully, and you look at age-related incidence and mortality, it's a different story. On the bottom, we can see the incidence and mortality for patients that are 65 years old or greater, and indeed, the incidence and mortality for this group is going down quite significantly. For the group that's 50 to 64, the incidence and mortality, the incidence at least is similar, with not much change, and the mortality may be going down slightly. However, the incidence is rising for those young patients less than 50, and I'm just showing that graph here. Over the last 20 years, there's been a steady rise in colorectal cancer for both males and females, with a beginning of a decline in mortality, a first decline and then maybe a rise in mortality associated with this incidence. This is a worldwide phenomenon. We're seeing it in every country, and I'll talk a little bit about the disease. Interestingly, this is mainly an increase in left-sided colon cancer and rectal cancer. You can see in green the rates of rectal cancer going up from 2.6 per 100,000 in 1991 to 4.8 in 2012, 2.7% annual increase. Similarly, in red, we see an increase in distal or left-sided cancers, again, 2.1 annual increase in those patients less than 50. And proximal colon cancers are about the same or steady incidence. So it's really left-sided disease that we're seeing in these young patients. Now, we recently published an analysis of what we called early onset colorectal cancer and compared it to average onset. We looked at baseline characteristics, somatic genomic alterations, survival and response, and then germline alterations. About 750 patients in the early onset group and about 690 patients in the average onset, with some subgroups for different analyses. This was all stages, and I'll go through it. We broke down the early onset colorectal cancer into two groups: early onset colorectal cancer between 35 and 50, and very early onset colorectal cancer less than 35. In these tables, I'll walk you through are the characteristics of those patients with very early, or average onset colorectal cancer. And on the left, we can see that the gender, race are the same in these categories. Of course, the younger patients have lower BMI, especially the very early onset colorectal cancer between 14 and 35. And similarly, there's much less smoking in this cohort. But the stage of presentation, the stage of disease, the differentiation on the left is the same, no difference. Now, all the way on the right, you can see the distribution, and I already told you that there's an increase in the left-sided tumors. And indeed, on the bottom in the blue, in that figure of the colon for the average onset colorectal cancer, there's about 60% in our cohort that is in the sigmoid, rectosigmoid, and rectum. But for the early onset cohort, that's about 75% in the sigmoid, rectum, or rectosigmoid. So the majority, again, being left-sided tumors. Now, this impacts how these patients are presenting. The early onset colon cancer patients are generally presenting with blood per rectum and not with anemia. It's the opposite for the average onset. This is probably related to right-sided tumors having, occult blood loss that can last for many months or years that isn't picked up. Now, if we look at the response to treatment, you can see on the left, this is for stage 4 disease, percent response to first-line treatment for our three groups, very early onset, and average onset. The response rates are the same, and the survival in the stage 4 groups is identical. That is, the early onset disease does not appear to be more aggressive or more lethal. This is the Oncopret looking at the somatic mutation of those patients in early onset, very early onset, or average onset. And the Oncopret is similar, meaning that the somatic mutations are very similar between the early onset colorectal cancer and the average onset. And this has been reproduced by others as well. We had always assumed that there would be differences, but that's not what we're seeing. Now, if we look at germline mutations, that is where we start to see a difference. The germline mutations, there's a higher prevalence, 23% of germline mutations in the very early onset colorectal cancer, including mutations in high penetrance cancer susceptibility. That's shown on the left. So to summarize this part of the talk, I would say that early onset colorectal cancer is generally left-sided tumors and they're presenting with rectal bleeding. There's a lack of genomic and biologic differences. There's more germline mutations in the very early onset, but the disease is not more aggressive. There's similar clinical outcomes and response to chemotherapy, and therefore aggressive treatment regimens based solely on colorectal cancer diagnosis age is really not warranted. Now, what's causing this increase in young patients having colon cancer? We don't know. We assume it's environmental exposures and associated epigenetic changes, such as those related to dietary or lifestyle changes. Increased saturated fats, obesity, sedentary lifestyle, it's all very unclear. Exposure to antibiotics or other drugs, we don't know. There's active research looking at the microbiome, as this is a field that has gained a lot of excitement, and I think there's going to be some very good research in the future. I think it's important to keep these young patients in mind, and that we have to investigate rectal bleeding, although it's a common symptom in patients these days. So I'm going to switch to the second topic, and that is adjuvant therapy for colon cancer. And I want to talk about the IDEA collaborative. Now, this was published in 2018, but it's really quite important and has been practice changing. The International Duration Evaluation of Adjuvant Therapy, or the IDEA collaboration, was a pre-planned pooled analysis of 6 prospective randomized trials evaluating the non-inferiority of 3 months versus 6 months of adjuvant therapy with either FOLFOX or CAPOX. They looked at 3-year disease-free survival with almost 13,000 patients and 3,300 events. And therefore, with such large numbers, you can identify small differences. Although the trial said that 3 months was that they could improve non-inferiority, when you broke down by the type of chemotherapy given, CAPOX versus FOLFOX, 3 months of CAPOX was non-inferior, therefore equivalent. However, 3 months of FOLFOX likely is not. You can see the disease-free survival overall for the 3 versus 6 months. These curves are almost on top of each other. There's such big numbers that they can find small differences, but they're not clinically important. This is the overall survival based on intention to treat those treated with CAPOX or FOLFOX, and you can see again, the curves line up completely on top of each other. So I pooled the oncologists at Sloan Kettering, and this is in general how we're treating these patients. For stage 2 patients, low risk, that is T3N0 without any high risk features, the majority are being observed, again, independent of age. If they get chemotherapy, it would be 5FU for either 3 or 6 months. Now, if you're a high risk stage 2, that is T3-4 with high risk features like lymphovascular invasion, perineural invasion, or tumor budding, then the choice is either 5FU or FOLFOX or CAPOX, and the majority would go with CAPOX for 3 months. And for other stage 3 disease, the group uses 3 months of CAPOX. And if it's very high risk, they may add an additional 3 months of oral 5FU. But the oxaliplatin is always dropped at 3 months due to toxicity. This is a major advance because it reduces oxaliplatin toxicity, which can be lifelong in up to a quarter of patients. Now, along the lines of adjuvant chemotherapy is the dynamic trial presented at ASCO 2020 and simultaneously published in New England Journal of Medicine on June 4th. This is a very exciting trial where stage 2 colon cancer patients were randomized into 2 programs to determine if they should get adjuvant chemotherapy. In one, based on standard criteria like I talked about, patients with lymphovascular invasion, perineural invasion, those would receive adjuvant chemotherapy, and those without these high-risk features would not. In the experimental arm, the patients had liquid biopsies to determine ctDNA, and if the ctDNA were positive, they got adjuvant chemotherapy, and it was negative, irrespective of other factors, they did not get the chemotherapy. And the hypothesis was that ctDNA-guided approach could identify minimal residual disease and therefore reduce the use of adjuvant chemotherapy without compromising risk. The The findings, there was a 2-to-1 randomization in the ctDNA cohort with a little over 300 patients. 15% received adjuvant chemotherapy with a 2-year recurrence-free survival of 93.5%. In the standard cohort, 150 patients, 28% received adjuvant chemotherapy based on standard criteria with a similar 2-year recurrence-free survival of 92.4. These Kaplan-Meier curves on the right side looks at disease-free survival based on which treatment algorithm you followed, and they're identical. And on the left just shows you the worst outcome in ctDNA positive patients, indicating indeed it's identifying patients with minimal residual disease. However, not all the patients are recurring. So I think the dynamic trial is very interesting as it's really the first individualized decision-making for adjuvant therapy. And it resulted in a 46% reduction in the use of postoperative chemotherapy. Important because of the toxicity of the oxaliplatin. Now this used tissue-based strategy. This was a tissue-based strategy in which ctDNA probes were personalized based on the primary tumor, based on the specific mutations in the tumor. It has very good sensitivity with a variant allele frequency of 0.01%, that's standard, very high specificity, but it's resource and time intensive. That is, you have to get the tumor, you have to profile it, you have to make your probes or pull your probes, and then study the ctDNA. A tissue agnostic approach in which you don't have to know the mutations in the tumor, which of course would be easier to apply. And these do exist. The question is, are they as sensitive and specific? This would be less expensive and easier to apply to a larger population. This is all being studied in additional trials, in addition to the use of treatment escalation for CT positive patients. So I think there's a lot to come here. This is a very exciting field and I think a big advance. Well, let's move over to rectal cancer. Total neoadjuvant therapy has now been popular for many years, and that's the idea that you move all treatment upfront before surgery. So for locally advanced rectal cancer that you would treat with chemoradiation, rectal surgery, and chemotherapy, you move the chemotherapy up front. The rationale for this is better tolerance of chemotherapy. And in some very large prospective randomized trials like the EORTC, only half the patients receive adjuvant chemotherapy after rectal surgery due to toxicity, poor recovery, infection, or other complication. We think this is important because early exposure of potential micrometastases to effective chemotherapy should cure more patients. It also optimizes downsizing for surgery or watch and wait. I'm going to touch on those. This is an example of a micrometastases. This is the type of disease that can be cured with chemotherapy, whereas macrometastases almost never are. We did a retrospective review comparing the standard approach to total neoadjuvant therapy. And as others have shown, you're more likely to get chemotherapy if you get into the patient, if you give it before surgery than after, either 8 cycles of 5-FU or 8 cycles of oxaliplatin. Much higher rates of tolerance if it's given before surgery than after. And this results also in an increased response rate, pathologic or clinical complete response. The blue shows the TNT approach on the left. And almost 50% of stage 2 patients would have a complete response as well. So this really created huge excitement to move to TNT, but it was only recently, again, the complete response rate, this is the idea of non-operative management, rectal preservation. On the left, you see a primary tumor after treatment and then 1 year after treatment. The idea that if the tumor responds completely clinically, you can watch patients and operate only if the tumor regrows. And you can avoid surgery if it doesn't. Again, optimized with TNT. Now, the benefit of TNT from an oncologic standpoint was only recently proven in two studies, RAPIDO and PRODIGE 23. And let's talk about both of those. The RAPIDO trial took locally advanced bulky rectal cancers and treated them with total neoadjuvant therapy or a standard approach. Now, it's important to know that these were very bulky tumors. They were either T4, had EMVI, extramural vascular invasion, had many suspicious lymph nodes, or involved mesorectal fascia or lateral nodes. Those patients received short course radiation followed by Capox or Folfox and then surgery. Or in the standard arm, they got chemoradiation, surgery, and then adjuvant chemotherapy based on where the patient was treated and treatment protocols. And on the right, we can see recurrence curves. The higher the curve, the worse, the higher the recurrence. And in the red is the standard, and the blue is the experimental group. And you can see metastases-free survival, and therefore disease-related treatment failure, was improved in the TNT group. And this would indicate that TNT is helping is reducing these distant recurrences by early exposure to chemotherapy. That would be the hypothesis. PRODIGE 23 similarly showed improvement in the TNT group. Now, this was a slightly different trial. This was a standard T3, T4. Patients received the triplet FOLFIRINOX, then chemoradiation, surgery, and then additional FOLFOX. That's the experimental group, the TNT group. The standard group got chemoradiation, surgery, and then adjuvant chemotherapy based on the local protocols. And again, metastases-free survival and disease-free survival was improved in the TNT group. That's the red curve. So again, PRODIGE 23 and RAPIDO show oncologic benefit to TNT. It is important to know that overall survival was similar in both groups, and this is likely related to length of follow-up, survival after recurrence, second, third line treatments and surgery. Next, I'd like to talk about organ preservation, and this is the OPRA trial. This was published this year in JCO, presented at ASCO last year. This is the organ preservation in patients with rectal adenocarcinoma treated with total neoadjuvant therapy. This was led out of Sloan Kettering with Julio Garcia Aguilar as the PI. This is the schema, and it's worth taking a moment to look at this. This is a phase 2 randomized trial. All patients received total neoadjuvant therapy, but the order of treatment was switched. So you either received upfront induction chemotherapy with Folfox or Capox, followed by radiation and then evaluation, or chemoradiation on the bottom line, consolidation Folfox or Capox, and evaluation. The disease-free survival was the same in both groups, but organ preservation was significantly higher if you received the radiation first. This is TME-free survival. That means you're free of disease and your rectum's in place. 60% rectal preservation versus 40%. Now, if we go back to the schema, the obvious difference between these groups is the time from radiation. If you receive radiation first, you have about 30 weeks from the end of radiation to evaluation, and we know radiation continues to work for many months. However, if you receive the radiation second, you're evaluated after a much shorter period of time. Now, this confounder really we cannot adjust for this. And so it may be that investigators or clinicians get nervous waiting in the group that gets induction chemotherapy. We don't really know. But in any case, the results show that the chance of rectal preservation, for whatever reason, is higher if you give the chemoradiation first. So Next, I'm going to talk about a very exciting trial that was also presented at ASCO 2022 and simultaneously published in the New England Journal of Medicine on June 5th, 2022, a study out of Sloan Kettering that looked at PD-1 blockade in MMR deficient, locally advanced rectal cancer. The MMR deficient or MSI rectal cancers we know are responsive to treatment in the metastatic setting. These tumors are very responsive, although not necessarily cured. And in this trial, we started off with the plan for 6 months of immunotherapy. After 3 months, patients were evaluated. And then if they had a complete response, they were followed. If they had an incomplete response, they got chemotherapy and radiation and surgery. This includes, it's a small trial, 16 patients, 14 evaluated, but they were mostly T3, T4 with 94% having clinically positive nodes. The responses are here. And what you can see is that all tumors, all 14 that were evaluated had complete responses. They all went to 0% viable tumor. And that's why there was so much stir for this study, that all patients had complete response, avoided radiation, avoided cytotoxic chemotherapy, and avoided surgery. This is a typical example. The baseline over here, 3 months after immunotherapy, a complete clinical response sustained at 6 months. The MRI goes from the tumor, turns into scar, especially at 6 months, and the PET scan goes cold. This is a very exciting trial, but of course is applicable only to MSI rectal cancer, which is rare. It's about 5% of all rectal cancers. However, if you're one of those 5%, there's a very good chance you can avoid an APR if you have a low tumor or a low anastomosis, or avoid the toxicity of systemic conventional chemotherapy or radiation. Now, lastly, I'd like to end with the PROSPECT trial. This is preoperative radiation or selective preoperative radiation and evaluation before chemotherapy and TME. This is a trial that asks, can we give just chemotherapy and avoid radiation for rectal cancer? This will result and should be presented at ASCO 2023, so next year. It's based on a pilot study at MSK where we gave patients FOLFOX chemotherapy, and if they had a good response, they went right to surgery, and if they didn't, they got radiation. It was a small pilot of 32 patients, but everybody responded. No one got radiation, and over 60% had more than 80% tumor kill. So that's very exciting for just FOLFOX chemotherapy and avoiding radiation. This led to PROSPECT, which is a 1,000 patient prospective international randomized study. It is accrued. We're awaiting data maturation, where patients were treated along the standard arm with chemoradiation, surgery, and adjuvant chemotherapy, or upfront chemotherapy, assess response, go straight to surgery if you have a clinical at least 20% response, and if you don't, you get radiation and standard treatment. Again, these will come out next year. So I'd like to summarize and say that early onset colorectal cancer, this is mainly left-sided disease. Patients are presenting with blood per rectum. I think we need to be aware of this with our younger patients. Pathology, somatic mutation, outcome is comparable to average onset. The very early onset, those less than 35 have increased germline changes. They should all be checked. They should all undergo genetic testing. The IDEA collaborative and adjuvant chemotherapy tells us that 3 months of CAPOX is sufficient for stage 3 colon cancer. We can avoid the toxicity of oxaliplatinum by stopping it at 3 months. The dynamic trial tells us that ctDNA and liquid biopsy appears to be able to tell us which stage 2 patients need adjuvant chemotherapy and which do not. And by using this approach, we can reduce the proportion of patients that get chemotherapy without affecting long-term recurrence. Total neoadjuvant therapy for rectal cancer is better tolerated with increased response. RAPIDO and PRODIGE 23 show us reduced distant recurrence, but same overall survival. This is quickly becoming the standard of care. The OPRA trial tells us about watch and wait, higher rates of rectal preservation with chemoradiation followed by consolidation chemotherapy, but similar overall survival. Immunotherapy for MSI rectal cancer is very exciting. It can avoid the toxicity of standard treatment, but has a small applicable group of about 5% of rectal cancers. This brings up the point that all rectal cancers should be tested for MMR proteins to identify these patients. Lastly, the PROSPECT trial asks if we can use chemotherapy alone for locally advanced rectal cancer, and that'll result next year. This is how we approach rectal cancer now, given the OPRA and potential PROSPECT results. If you have a mid to upper rectal cancer, the thought is that you can get chemotherapy and surgery. That should result in excellent oncologic outcomes with minimal effect on bowel function, very acceptable effect. You're avoiding the radiation, which plays a big role in poor bowel function after low anterior resection. For low rectal cancers that need APR or coloanal anastomosis, we should start with chemoradiation and then consolidation chemotherapy before evaluation for surgery or watch and wait. The only thing we have to look out for is for a patient with nair obstruction or who is mildly symptomatic. Those patients should receive upfront chemotherapy followed by chemoradiation because the tumors respond very quickly to chemotherapy. Symptoms improve in 1 to 2 weeks after starting treatment. Obstructions resolve. On the other hand, if you start with chemoradiation in a near or partially obstructed patient, it takes a long time to get radiation started, and you often can get tumor edema, which could make it worse. So very low tumors start with chemoradiation. Unless they're stenosed or nearly obstructed, then we would start with chemotherapy. Thank you very much.
My question is now if the patient need APR or coloanal anastomosis, do you test the MMR protein for all of that patient?
Yes, absolutely. We test MMR on every rectal patient that comes in the door just for that reason. It's important also for rectal cancers because you want to get tissue before they respond, and if the tumor goes away, you will lose that tissue. So if you want to do any testing, it should be done before they start treatment.
Yes, and for the MMR protein, do you test full band of it, mean the MSH1, or all of them from biopsy specimen?
Currently, we're testing all of them, yes.
Yeah, thank you very much.
Thank you very much, Professor. Can I ask you for your opinion about the induction or consolidation TNT in the case of not locally advanced and don't have a EMVI is negative, CRM negative? Just case like this, do you still recommend induction, or maybe consolidation is more better?
Yes, so that's a very good point. If it's not a very low tumor without very high-risk features, then although we don't have PROSPECT results yet, we're betting that is going to be a positive trial. I think it makes sense to give induction chemotherapy and reassess because they may be a candidate to go straight to surgery without radiation. I think this is especially important in young patients, especially women who want to maintain fertility, where radiation, of course, would make them infertile.
Thank you very much. Thank you very much, Professor Weiser, for your time. And we'll talk to you later, Marty. Thank you very much for your excellent talk.
Okay.
Thank you very much. See you.
Thank you. Thank you,
Yeah.
Joe. Bye-bye now.
Bye bye.